Good afternoon, everyone. Welcome to the McLean Hospital Borderline Personality Disorder Education Webinar Series. My name is Dawn Sugarman. I'm a psychologist at McLean Hospital and Harvard Medical School, and I'm the Associate Director of the Borderline Personality Disorder Patient and Family Education Initiative. So before we begin, I just have a few logistical announcements. To protect your confidentiality, all of your microphones have been muted, so we ask that you please use the Q&A box at the bottom right-hand corner of your screen to type in your questions. You can type in your questions at any time, and we encourage you to do so. If you'll also notice at the bottom of your screen, there's some web links that we have listed. The first link is for our website. We record all of our webinars, and we post those recordings on our website. So if you have not seen some of our previous webinars, please check us out at our website. We also often get questions about referral resources, so we've listed 3 websites here that can help you find resources and referrals in your area. So we have the Borderline Personality Disorder Resource Center, NEA-BPD, and Behavioral Tech Clinician Directory. We have also a link for our October 13th webinar, and that will be with Dr. Jillian Galen on validation. So please click on that to register for our October webinar. And I also want to mention that our initiative is funded by a generous donation from a family affected by borderline personality disorder. But if you would wish to make a gift to support the series as well, you can see the link to give to that as well. So now I want to get on to today's topic, which is common causes of treatment resistance and possible solutions. And our speaker is Dr. Christopher Palmer. Many of you who have joined us before may recognize Dr. Palmer. He is typically the moderator of our webinar series. Dr. Palmer is a practicing psychiatrist at McLean Hospital, and he's the director of the Department of Postgraduate and Continuing Education at McLean Hospital as well. He is also an assistant professor of psychiatry at Harvard Medical School. So with that, it's my pleasure to turn over the microphone to Dr. Palmer.
So good afternoon, everyone. It is really a pleasure and an honor to be able to talk with you tonight and share some of my thoughts on treatment-resistant borderline personality disorder. This is a topic that has come up quite a bit, and I know some of our webinars have not always focused on it. Some of our webinars have focused on the basics of treatment when somebody first comes into treatment. But one of the questions that we've often gotten from a lot of participants is, what do you do after years and years of this? And the person just doesn't seem to be getting better. And I'm hoping to do a very broad overview and hopefully give you some food for thought in terms of what might be going on and what might be helpful. So to get started, I'm going to just make a couple of points on what is borderline personality disorder. Given that you are attending this webinar and it's focused on treatment resistance, I'm going to assume that all of you know what borderline personality disorder is. So I'm not going to read through the criteria. I'm going to assume you know them, but they're here in case you don't. Read fast. But the big point that I want to make about what is borderline personality disorder is that, like all psychiatric disorders, it is a syndrome, which means that we do not know what causes it, and we do not have an objective test to test people for borderline personality disorder. So instead, we have a checklist of symptoms. And for borderline personality disorder, and I'll say BPD to abbreviate that, for BPD, we have 9 different symptoms, and they're all listed here. And you have to have 5 or more out of the 9 symptoms, and then you get borderline personality disorder. A couple of points I want to make about that, though, are that 2 people who are diagnosed with borderline personality disorder can look and act very differently. And in reality, they probably do have a different illness, or at least a different constellation of things going on. So for instance, one person might have a prominent symptom of cutting and self-injury, whereas another person diagnosed with BPD may not do that ever. Another person with BPD might have a lot of anger outbursts, and that might be most prominent in people's minds. And so they think of BPD as lots of anger outbursts, whereas other people diagnosed with BPD never have an anger outburst. They're actually quite shy, quite passive. And so that's the first point I want to make. And then next, we're going to go on to, so what causes borderline personality disorder? Because this always comes up. When you're talking about treatment, everybody's going to ask, so what causes it? And I want to reiterate the point, no one knows for sure. And even though that's such a frustrating message that no one knows for sure, I want to give it to you because it's also a message of hope. So when things aren't getting better, and some clinician has told you, like, we know what causes this, and if this isn't working, it's just, there's no hope, I want to reiterate, nobody knows for sure. And so there are always new things to try, and always new approaches. And I've never met a patient once who's tried everything. But here's what we know about what causes it. So the first two kind of go together. So we know that there's a genetic link for borderline personality disorder. People who have a first-degree relative with BPD are more likely to also have the illness. And, but just more likely, it's by no means strictly genetic. And then there are these brain abnormalities that have been found in borderline personality disorder. And so there are differences in the structures of the brain that regulate emotion, for instance. And there are also differences in some neurotransmitter levels. So those are brain abnormalities. Now those could be caused by genetics, but they could also be caused by environment, things like diet, exercise, parenting, traumatic experiences, other things can all affect brain development. So we really don't know why those differences exist. And again, they're not consistent enough for us to be able to make a definitive diagnosis of borderline personality disorder, but we have some little clues, and so we think that those things are involved. And then there are some other theories, poor attachment in childhood and poor ability to mentalize. And mentalize is, I'm using it as a verb here, it's really the ability to understand how you feel and how you think about the world and how other people feel and think about the world, and then kind of have relationships with people based on those two things. And so some theories about borderline personality disorder speculate that people who never learned how to mentalize or had poor attachments in childhood maybe are more likely to develop borderline personality disorder, or in fact maybe that's the cause of borderline personality disorder. There's a psychodynamic theory that borderline personality disorder is caused by a split sense of self and others. So one easy example of this is somebody who feels love toward a parent, and so that person would say, I love my parents. And yet every now and then they get angry at the parent, and at those moments they think, I hate my parent. And they're not able to really integrate those two states of mind. So it's all or nothing. It's either I hate my parent or I love my parent. And you get these extreme reactions both ways. And the therapeutic process in that case is trying to integrate those things. And then there's a big camp that believes that borderline personality disorder is caused by abuse, sexual abuse, physical abuse, especially in childhood, or neglect. And so I want to make a couple of points. One is that some people believe that there is no such thing as borderline personality disorder, some clinicians. They think that it's all post-traumatic stress disorder, and usually they call it complex PTSD. So that's one theory. And I want to put that out there because we're talking about treatment-resistant cases. And so if you have dealt with a lot of clinicians, you may have heard that. Other people on the very different side of the spectrum feel like there's no such thing as borderline personality disorder. It's all bipolar disorder. It's just a strange variant of bipolar disorder, and those patients need mood stabilizers. There's a little bit of support for that, as I'll discuss, but by no means do I actually think that's accurate either. And so, sorry, I skipped ahead. So what does getting better from borderline personality disorder look like? And that's a common question, and when we're talking about treatment resistance, we want to know, well, what's the end outcome supposed to be? And so I'm going to tell you a little bit about the McLean study of adult development, which was done here at McLean Hospital by our own Mary Zannarini. And Dr. Zannarini presented a lot of this research in one of the earlier webinars. So if you want more in-depth information, feel free to go back to that webinar. But I'm going to summarize a couple of main points. So she ended up following 362 people who were hospitalized here at McLean 20-some years ago, and 290 of them had borderline personality disorder. And she's followed them for over 20 years now to see what happens and what are the outcomes. And they ended up creating kind of two definitions. One was remission and one was recovery. So remission they defined as people no longer meeting symptom criteria for borderline personality disorder. So do the symptoms of BPD last forever? Are they really part of your personality? Do they just go on forever? Because that's a common perception. And many clinicians still believe that. And the reality is what they found, after 16 years of following these people, they found that 99% of them would have at least a 2-year period of time, where they no longer met criteria for borderline personality disorder. If they got that 2-year remission, 36% of the time there was a recurrence of symptoms so that they actually met criteria for BPD again. But 4 out of 5 people, 78%, achieved an 8-year or longer remission of symptoms. And of those who achieved an 8-year remission of symptoms, only 10% had a recurrence. And what this tells us is that borderline personality disorder, in fact, is not a chronic illness. It can last for several years or longer, but it usually is not a chronic illness. It is not a persistent trait for the rest of one's life. But then they looked at another thing. They looked at recovery. And how did they define recovery? Recovery was defined as not only remission of symptoms, but also having at least one sustaining, beneficial relationship with either a friend or a romantic partner. Family members didn't count. And they had to be participating in full-time work or school. Part-time did not count. And what they found is that after 16 years, 60% of the participants achieved a 2-year recovery, and among them, 44% would eventually lose the recovery. So losing the recovery could be a recurrence of symptoms, or it could be going from full-time work to part-time work, or losing the job and having no work, or losing the relationship. And 40% of them achieved an 8-year recovery. And that was more durable, because if you got to an 8-year recovery, only 20% of them would lose that recovery. And so that's really important. The one thing that they did find is that the most common reason for not getting recovery was the lack of full-time work or school. About 50% or so of people did not work and were on disability usually. So what does remission look like? So I've defined remission, no longer meeting symptom criteria for BPD, but what does it look like? It does not mean the absence of symptoms. So remission just means you don't meet criteria anymore. And meeting criteria means you have to have 5 to 9 of the symptoms. So if somebody has 4 of the symptoms still, they would be in remission, even though those symptoms might be causing problems in their life. And usually when people have remission from borderline personality disorder, some of the traits that usually persist are mild depression, some anxiety, rejection sensitivity, and a little bit of less tolerance towards stress. So when things get really stressful, when relationships end, things can unravel a little bit, they're more susceptible to getting moderately or severely depressed in those circumstances than the general population. And so why the lower rates of recovery? If remission is so high, 99% achieve at least a 2-year remission, that's pretty significant. So if all of these people are going into remission, why aren't they recovering? And no one knows the definitive answer. Some speculations are that maybe the symptoms that persist are preventing them from working. Another speculation is that maybe the medications that they're on that got them into remission are now causing cognitive side effects or something, and that those cognitive side effects of the medication are preventing them from working. But I'm going to give you another speculation, and another speculation is the fear of relapse and mindset. And I'm going to be talking about that in a little bit. So what is treatment-resistant borderline personality disorder? Unfortunately, I'm a person who's here to tell you we don't know either. There is no clear working definition. The field of psychiatry doesn't have a working definition of treatment-resistant borderline personality disorder. So I'm going to propose one. These criteria were mostly proposed by Glenn Gabbard, and I'm going to concur with them for the most part, that it might be somebody who continues to self-harm or makes frequent suicide attempts after 1 or more years of treatment. After 1 or more years of treatment, that should not be happening anymore with effective treatment. Somebody who has serious symptoms of depression, anxiety, mood instability, or impulsivity, after 2 or more years of treatment, those symptoms might take 2 years to get better, but you should see some improvement, certainly, within 2 years of treatment. Serious impairment of functioning after 2 or more years of treatment, or just repeatedly dropping out of treatment. So somebody who just won't stay in treatment long enough to get better, even though their symptoms are persistent and they're not functioning well. So what causes treatment resistance? Again, no one knows for sure, but here are some possibilities. So the one that usually gets thrown around is they didn't get good treatment. So less than optimal treatment is certainly a strong candidate. It could be the wrong diagnosis. A lot of people who probably have borderline personality disorder are never diagnosed with it. Instead, they're diagnosed with depression or anxiety or an eating disorder or something else, and nobody ever addresses the borderline personality disorder. Sometimes it can be uncoordinated treatment or splitting. So what that means is that when somebody is going to a psychotherapist and a psychiatrist for medications, that those are 2 different people, and those people aren't talking. Sometimes they can wreak all sorts of havoc. They can go to the therapist and talk about how depressed they are and how they're really not going to be able to make any progress in treatment until that stupid psychiatrist gets the right medication. And then they go to the psychiatrist, and the psychiatrist is getting burned out and feeling like, what's that therapist doing? That therapist needs to be like helping you, because I don't have any medicines. We've tried 20 medicines, and none of them are working. I think your therapist needs to be doing a better job. And then it's just kind of a big bickering match, and the person's not getting better. Sometimes it's incorrect or unrealistic expectations about different aspects of treatment, especially medications, and I just alluded to that. Kind of looking to medications to solve all of the symptoms of borderline personality disorder, and I'll talk about that a little bit. Sometimes it can be incorrect or too many medications. Sometimes it can be other diagnoses that aren't recognized or addressed. And I want to highlight ongoing trauma. So somebody who's in an abusive relationship, that will clearly interfere with treatment of borderline personality disorder, as well as treatment for probably anything else. And somebody who's actively abusing or even sometimes using alcohol or recreational drugs, that can absolutely interfere with recovery from BPD. Having a worse illness than others have. So this often gets thrown around too. Why aren't they getting better? Well, they've just got a really bad case of BPD. And it must, we don't know. And then the final thing I'm going to talk about is our mindset. And I'm going to come to that in a bit and go in quite in depth. So is it really just borderline personality disorder? I said, if there are other diagnoses, that makes it more likely that treatment's going to be more difficult. And here are all of the co-occurring disorders that are pretty common with borderline personality disorder. They include things like depression, bipolar disorder, substance abuse, eating disorders, post-traumatic stress disorder, anxiety disorders, and so on. They also include medical conditions like headaches, fibromyalgia, chronic fatigue syndrome, irritable bowel syndrome, and all of these others. And if somebody has 1 or more of these co-occurring disorders, and those disorders aren't being recognized and addressed, that will interfere with the treatment process and recovery. And now I've hinted at it or mentioned it a couple of times, mindset. And I want to spend a little bit of time on mindsets because when we're talking about treatment-resistant illness, mindsets end up being really important. People get so frustrated and so burned out. The people with borderline personality disorder who are being treated are just tired of it and feel like there's no hope, I'm not getting better. The parents and other loved ones are getting tired and frustrated and feeling like this isn't working. What can we do? The treaters oftentimes are getting frustrated and burned out if symptoms are persisting and nothing's getting better. And mindsets affect all of those people. So I want to speak a little bit about a book. It's a book called by Carol Dweck. It's titled Mindset, the New Psychology of Success. And it's really a book that is primarily geared toward educators. It's about teaching children in school. And she has a hypothesis. Her hypothesis is that people go around with one of two mindsets. That a lot of people have a fixed mindset and a lot of people have a growth mindset. And a fixed mindset is this belief that people are born with inherent traits, such as IQ, and their success in life, in school, in work, and everything else is largely based on those inherent traits. So easy example, a child is born smart. This is a really bright kid. He's showing a lot of promise. He's got a lot of talent. He's going to go places. Teachers take interest in him. Parents put a lot of effort into that kid because he's so smart. He's going to do well, and everybody expects him to do well. Or a kid's not so bright. This one's not so bright. This one's stupid. This one's whatever, slow. And what happens? Teachers don't invest much time in that kid. When that kid can't do math, nobody really challenges it too much because, what do you expect? He's not so bright. He can't do it. But there's a different mindset, and that's called the growth mindset. And the growth mindset assumes that people can learn new things and grow. So success, in fact, is not based on inherent traits. It's based on how hard they work to learn new things and how flexible and adaptable they and their teachers, parents, and managers can be in helping them to learn. So it doesn't ignore the fact that there are differences, inherent differences in people. Some people do have higher IQs than others. There's no questioning that. And the people with higher IQs probably have an easier time learning. There's no questioning that. But it doesn't mean that people with lower IQs can't learn. It doesn't mean that people with lower IQs can't get certain jobs. It doesn't even mean that people with lower IQs can't be even more productive than people with higher IQs. Because there's more to success than IQ. And lots of studies are finding that. So the easy example is this child who's having difficulty learning math. If a child is having difficulty learning math, and everybody's assuming he's not so bright, he's not good in math, the teachers don't put much effort into it, he's not going to learn much math. And what is he going to say to himself? He's going to say, I hate math. He's going to be angry. I hate math. I hate this class. I hate this teacher. Or he's going to get depressed. He's going to get down on himself. I'm so stupid. I'm worthless. I don't know what's wrong with me. Why, I don't know what to do. Or people could have a growth mindset. They could say, this child is struggling in math. Maybe the lesson we're giving him isn't the right lesson for him. Maybe if we talk to him in a different way, if we teach it in a different way, if we explain it in a different way, he'll be able to get math. And the determined person says, no, all my kids are going to learn math, and this kid's going to learn math. It might take more effort. It might require more planning and more innovation, but we're going to figure out a way to teach this kid math. And what is that kid going to say? That kid is going to say, yeah, math is really hard for me. It's really challenging, but I want to learn math. I need to learn math. It's important for me in my life, and therefore, I'm going to work harder. Maybe I have to spend more time on math than everyone else, but that's okay, because I want to do well. So how does this apply to borderline personality disorder? Well, I'm going to make the argument that these mindsets, a fixed mindset and a growth mindset, are pretty prominent in the way people think about borderline personality disorder. So the fixed mindset suggests that borderline personality disorder is a disorder that persists for life, and so many clinicians still believe that to this day. There are clinicians who don't want to work with people with BPD because it's just too frustrating for them, and there's no use. They're not going to change. So some examples of this mindset. Somebody might say she'll always be moody and irrational. It must be genetic. I don't know how she'll ever be able to take care of herself. He's never going to change. She must want to be this way because she keeps doing the same thing. Somebody who's been traumatized, people might say, oh, she's so broken and weak. Maybe she's just too damaged to ever get better and function or get a job. The people themselves might say, I'll need to be in therapy for the rest of my life. I don't know how I'd survive without therapy. Or they might say, I'll never be able to take care of myself. Those are all fixed mindsets. Growth mindset instead would, I'm going to give you one example of something to focus on. BPD symptoms remit in 99% of people for at least 2 years. They remit. So some examples of this growth mindset would be the symptoms of BPD can be challenging and interfere with life, but they can be understood. People can learn new skills to better manage the symptoms or even become symptom-free. Or they might say this is an extraordinarily difficult time, but it won't last forever. A therapist might say she's been trying these skills for a month now and they aren't working. Instead of saying she's treatment resistant, the therapist might say maybe we need to figure out why or come up with other strategies for her to use. And people might say even though that last job didn't work out, maybe we should try again. So what are the results of these two different mindsets? A fixed mindset leaves people feeling hopeless and helpless. It can lead to enabling or excessive caretaking. So if parents have this fixed mindset toward a child, they're more likely to kind of take the role of caretaker and or enabler. And it can lead the BPD sufferer to expect to be taken care of, and if they don't feel taken care of, to be suicidal. The growth mindset instead assumes that people with BPD are capable of overcoming symptoms, functioning, caring for themselves. It leaves people feeling determined to find solutions, and it encourages patience with trial and error to see what will work. So some other mindsets that I'm going to put in the camp of fixed mindset and growth mindset. These are all fixed mindsets, but they're very common in BPD. So one is, I'm unlovable, but then the subtext is, I desperately need to be loved. So this is a common fixed mindset that interferes with recovery. A lot of people with BPD will just have thoughts like, I'm so messed up, no one's ever going to love me, or they feel like they always have a secret. That like if somebody really knew everything about me, there's no way they would stay with me. It can lead to a helpless and suicidal stance when the person is feeling alone, or a desperate and clingy stance when they're feeling possibly loved. It can lead to a desire to remain in the sick role. So this can lead people to want to be sick, and I have heard this from dozens of patients. And they will say, the only reason my parents pay attention to me is because I'm sick, because I get suicidal. If I wasn't suicidal, my parents would jump ship. They would run so far away from me. It can lead some people to promiscuity. The only way to get anyone to pay attention to me is to have sex with them. It can lead to distortions and anger outbursts and erratic behavior in romantic relationships. So they'll ask themselves, why is this guy with me? For a woman, heterosexual woman, I should point out. For a heterosexual woman, why is he with me? And she'll get suspicious of him and say, well, he's either using me somehow or he's really stupid. And then that evokes anger. It can lead to excessive and unrealistic expectations of the need to be perfect. So these are the people who might develop an eating disorder and want to be excessively thin. These are the people who need to get straight A's and will like have an emotional catastrophic breakdown at a B+, because they have to be perfect, because they want to make up for this perceived deficit that they're so unlovable. And it can lead some people to remain in abusive relationships because they feel like they can't do any better. So another mindset that really interferes with recovery, it's not my fault. So this is a person who blames others or circumstances for their less than desirable behaviors or their lack of progress in treatment. The perpetual victim who lacks ownership over their own life. This is also pretty common in BPD. It can develop from post-traumatic stress disorder, but it can also develop from feeling that life has just been unfairly difficult, feeling weak and vulnerable, trying to entice people to rescue them, like all these people are being mean to me, my boss is being mean to me, you have to help me. or trying to understand or explain illness or symptoms. Sometimes people just feel so messed up, so disturbed, and they feel like they need an excuse. And I've had some patients actually create histories of abuse and later told me, I lied. I was never abused. It never happened. But I just felt like I needed a reason to be so messed up. In some cases, it can lead clinicians and loved ones to excessively caretake and enable. They're trying to rescue the person. This person's helpless. They're getting victimized all the time. I want to rescue them. But it can also lead people to get burned out, stop believing the person, and give up. And then the third mindset that I want to talk about is my life has no meaning. So this is really important because when I see people come to me who've had treatment-resistant borderline personality disorder, usually they've been in treatment for years, many years, if not decades. And when I ask them, like, what do you want to do? What's your life about? It almost always revolves around their symptoms and being a patient. And it's a really challenging mindset to address. And I think that part of it may have something to do with the core symptoms of borderline personality disorder. So two of the symptoms are identity disturbance and chronic feelings of emptiness. So that can leave people feeling empty, purposeless. But depression and hopelessness often challenge meaning and purpose in life too. I think that for some people, continued symptoms can lead to this. So they become a chronic patient and they're focused on their symptoms. And they feel like they can't move on with life, they can't do anything meaningful until their symptoms are resolved. For some people, it can be a fear of relapse. So even people who go into remission from borderline personality disorder, they can remember the living hell that they were in 3 years ago when they were attempting suicide, when they were cutting themselves, when they just had trouble existing. And so they don't push themselves for things that would be meaningful, like getting a job or helping people or being in a relationship, because they're terrified that that will trigger a relapse, that will trigger more symptoms. The stress of it will be too much, and they'll end up back in that living hell, and they just can't risk that. And so they just go on, sometimes on disability, sometimes pretty isolated, and they feel like I'm just going to have to make the most of this. But when you ask them, is there meaning and purpose in your life, they usually don't have an answer, or they're usually really sad, and they feel like, no, not really. And I would say that, in and of itself, interferes with recovery from BPD. Because at the end of the day, in my mind, when I'm working with patients, this forms the basis of treatment. This is the whole reason you're trying to get somebody better, is so that they can have a life again, and that they can have meaning and purpose. So what to do about all these mindsets? These are very, obviously we could go on for hours on that topic. But here are some basic pointers. So one is address these mindsets and beliefs directly. If you think these are going on for yourself or for somebody you know with BPD, talk about them. Do you feel unlovable? Do you feel like your life has any meaning and purpose? What do you want to do with your life? What would you like to do? One common question that gets asked about meaning and purpose is, when you're dead and somebody's reading your eulogy, what do you want them to say about you? And then ask them, well, what would you like them to say about you? And if there's a difference between those two things, ask them, well, how can you get closer to what you want them to say as opposed to what you think they'll say? It's important to validate feelings and beliefs. So one common thing that can be really frustrating for people, somebody says, I'm unlovable. And they really do mean it. They really do feel that way. It's a perpetual belief. It's easy for parents to say, that's nonsense, don't be silly, you're lovable. That's probably not really helpful because it dismisses their feeling. And it tells them, they're being stupid. Well, guess what? That just makes them feel weaker, more vulnerable, and it makes them feel like, well, if I'm stupid now, then I guess I really need to be taken care of. So instead, it's important for you to get it. So to just really listen and understand what are they feeling and how are they feeling it and why are they feeling it. It does not mean that you have to agree, because I then follow it up with share your concerns and beliefs and say, well, I hear you that you feel unlovable. That makes me really sad that you feel that way, but I'm hearing it. I get it. It explains some things, but I don't agree with it. I think you're lovable, but somehow we have to, I hope we can work on this, or I hope you can work on this with your therapist, or I hope you and I can talk about this more, because I disagree with you. But I do get it. I understand that you feel that way, and that's really sad. It's important to try to understand how they come to the conclusion. So in the same way that when the kid is having trouble learning math, if he gets the answer wrong, the math teacher doesn't say the answer is 15. Instead, the math teacher says, well, how did you arrive at that conclusion? And tries to understand their thought process about how they got to that conclusion, and teach them how to do it the right way so that they get to the correct conclusion. And it's going to be the same thing with these distortions and these beliefs. So moving on, we're going to do a whirlwind tour through treatments for borderline personality disorder. And this really is a whirlwind tour. Every single thing I'm going to talk about could be an entire presentation, if not an entire conference. But I'm hoping that this whirlwind tour will give you a lot of things to think about and a lot of areas to kind of assess. So psychotherapy. Psychotherapy is the mainstay treatment for borderline personality disorder. There are a lot of different types. DBT, MBT, TFP, STAPS, schema-focused psychotherapy, CBT, and GPM. And I'm not going to go into details or specifics on these. Some of our prior webinars did, and some future ones probably will. There's a lot of material out there for you to learn about them, but again, you could do entire conferences on each one of these, and you still probably wouldn't understand everything. But these are the mainstay treatments of psychotherapy. The biggest one that I want to talk about is general or good psychiatric management. And the reason I point out good psychiatric management is because a lot of people think that you need a specialist treater who specializes in borderline personality disorder and specializes in DBT in order to get effective care for borderline personality disorder. And good psychiatric management is actually for general mental health clinicians, psychiatrists, psychologists, social workers. And GPM has been found to be just as effective as DBT. So it's important to know about all these different treatments and what they have to offer. But I want to point out that you don't need a specialist in order to get better. One thing that I do want to point out about these different types of psychotherapy is that a lot of them are based on their own theories of what causes borderline personality disorder. So for instance, mentalization-based treatment is based on the belief that the cause of borderline personality disorder is poor attachment in childhood and therefore poor mentalizing ability. And so that whole treatment is geared toward teaching people how to mentalize, correcting that deficit. And I want to remind people that is one theory. And there's evidence that MBT works. There's no question about that. But just because something works doesn't prove that that was the cause. Easy example I give on that is that if somebody gets a headache and they take Tylenol, and the Tylenol makes their headache better, it doesn't mean that the cause of that headache was Tylenol deficiency disorder. It wasn't. The Tylenol helped the headache, but we don't know what caused the headache. And so it may be that MBT can help BPD even if mentalizing in childhood isn't the cause. It can go either way. So some main pointers about psychotherapy. Weekly individual sessions are usually warranted, possibly twice weekly in some cases, but much more than that can lead to overdependence on the therapist and kind of reward people for being sick. So if they're seeing somebody really frequently, a lot of times they'll want to come in with symptoms to talk about and problems to work on, and that's kind of rewarding being sick. And you really want to avoid those subtle reinforcing things with BPD. If one approach of therapist isn't working, think about another approach, because when one doesn't work, Others might. Some of them are very different. I want to stress therapeutic alliance is very critical. And basically what that means is that the person has to like their therapist. Therapist should like the person. And the person has to feel like the therapist is really trying to help. If that's not there, the first step should be the person needs to talk with the therapist and say, I don't feel like you like me, or I don't really like you, or I don't know that you can help me. But if they don't get any resolution, I would strongly advise getting a therapist that they feel some connection to, because that has probably consistently across most studies has been one of the strongest predictors of getting better, is an alliance with your therapist. Progress in therapy should be clear and measurable over time. And if you're not making progress, but the person loves the therapist, maybe consider a consultation. Medication. So I want to start out with saying no medication is FDA approved for the treatment of borderline personality disorder, and this is a really important point. Medications often do play a role in treating some of the symptoms of BPD, so they can treat depression, lability, anger, and usually for those we use antidepressants and mood stabilizers or atypical antipsychotics. Things like impulsivity, we use antidepressants, mood stabilizers, antipsychotics, and opioid antagonists. And for things like paranoia, hallucinations, or dissociation, we usually use atypical antipsychotics. The atypical antipsychotics are the best studied and treat most of the symptom categories of borderline personality disorder. And this, again, reinforces this notion that maybe borderline personality disorder is a form of bipolar disorder. I want to point out, most psychiatric medications take at least 2 weeks to even show a hint of working, and 2 to 3 months to really work. But many patients and clinicians don't wait this long to assess the effects. Increasingly, I think people across America are looking for pills to solve all their problems. With all the commercials on TV, there's a pill for this, there's a pill for that, isn't there a pill for this? Unfortunately, medications do not fix all of the problems of borderline personality disorder, and I want to make that abundantly clear, because all too often, when I have been referred patients with borderline personality disorder with treatment resistance, they have relied heavily on looking for the magic pill to cure them. And unfortunately, they haven't found it. In some cases, medications can actually cause psychiatric symptoms. So I want to repeat that. They can cause psychiatric symptoms. These are substances that affect the emotion regulation centers of our brain. And we know that when people are on a lot of them, they can cause psychiatric symptoms. And we know that when people withdraw from medication, so when they stop and start them, or when they're changing medications frequently, that can cause depression and suicidality and lots of other symptoms. And so sometimes when I see patients who've been changing meds every month, and they're on 6 medications, the first thing I do is say, let's give your poor brain a rest and stop changing meds and try to get you off some of this stuff. Because I don't know which of your symptoms are you and which of your symptoms are all these medications. So recommendations. So despite the scary concerns that I just gave you, which I still stand behind, please take that advisement. Despite that, you should and can try medications to see if they're helpful, because for some people they really are helpful. They will not cure BPD. If they cure BPD, you did not have BPD. You probably had depression or something else. So if they cure it, but medications can help a lot of the symptoms. And so for people who have been trying lots of things for more than a couple of years, the general guidelines that I give are you should try at least 2 different antidepressants, each taken for at least 2 months. So sometimes I see people who try antidepressants, but they only take them for 1 or 2 weeks, have side effects, and stop them. And they've never tried anything for 2 months. And that means you've never given it a chance to work. And they should try at least 2 trials of atypical antipsychotics. This is assuming things aren't working, things aren't getting better, the symptoms are persisting. Obviously if you try one and it works, then stay on it and continue your treatment. But if things aren't getting better, you should probably try at least 2 trials of atypical antipsychotics. And these often aren't used. A lot of clinicians are afraid of that word. A lot of patients are afraid of that word. But they are the best studied and actually found to be the most effective. Avoid prescribing new medications in reaction to the crisis of the day. I hope I've made that point. Avoid too many medications. If you need to stop something, you've got to taper off of it very slowly. Because when people come off too fast, they will get depressed and or suicidal easily. And it's really because you're coming off the medication. It's not because you need the medication. It just means that you need to taper off. Your brain needs more time to get used to not being on it. And if symptoms are persisting over years, you can and should slowly try new medications. So hospitalization, this always comes up in treatment. People sometimes want to send somebody to McLean. I'll send somebody to McLean for 2 weeks. You guys will fix her or him up and they'll be better. Well, inpatient hospitalization is really about emergencies of safety and rarely kind of provides definitive treatment. Partial hospitalization is something that lasts like 1 to 3 weeks. It's a lot of group programs during the day. That can be helpful when outpatient treaters are feeling overwhelmed or unsure about the treatment. And residential treatment, which is an unlocked longer-term treatment that lasts anywhere from like 2 to 6 months. That can be helpful when outpatient treatment is failing. Unfortunately, insurance coverage can be difficult for that, though. So what are some other prescriptions? So psychotherapy, medications, that's what usually gets talked about. And I throw these in because these are part of a comprehensive treatment program for BPD. And if you've got treatment-resistant BPD, these things might be at play. So structure, 1. If somebody doesn't really have a lot going on in their life, they don't have a schedule, it often leads to like, why get out of bed? There's nothing for me to do except feel depressed. Sleep. If somebody has disrupted sleep, or they're sleeping way off schedule, that can exacerbate borderline personality disorder symptoms and interfere with recovery. If you're sleeping from 6 a.m. until 5 p.m., you're not going to be able to go to school or work. Medications, sleep medications can sometimes be useful. Sleep hygiene can be useful. There are computerized sleep cognitive behavioral therapy programs that anybody can do on the computer that can be really helpful. And light therapy can be really helpful for regulating sleep and can also be really helpful in depressive symptoms. Even for people who do not have seasonal affective disorder, there's emerging evidence that light therapy can help depression just almost as well as, and in some cases just as well, as antidepressants can. So relationships, those are another prescription. A lot of times people with BPD will end up becoming isolated. They don't have many friends. They're not working. They're not in school. And relationships are a prescription. They have to develop friendships. They have to engage in relationships. Romantic relationships when things are a little more stable, yes. Exercise. Exercise has been proven to have huge antidepressant, anti-anxiety effects. The exercise can take the form of cardio, yoga, weightlifting. All forms of exercise have been helpful. More often than not, I often use yoga and or cardio because I've found that those two in particular seem to be more helpful than weightlifting. Mindfulness and meditation. We've heard about that in other webinars, so I won't go into detail. Diet. There's increasing evidence that people with BPD are much more likely to be obese. And we know that people who are obese, and especially people with diabetes, are much more likely to be depressed. And it does appear that the process of gaining weight, so somebody who is slowly but surely gaining 5 or 10 pounds per year, which may not seem like a lot, but the process of gaining weight in and of itself causes inflammation in the body. We know that. And inflammation in the body is highly associated with depression, mood problems, sleep problems. And so if somebody is obese, or if somebody is slowly but surely gaining weight, focusing on diet can be helpful in the treatment. School or volunteer job in preparation for employment, and then employment. And employment, I put down as a prescription. It is part of the treatment of borderline personality disorder. It's part of the treatment for everyone. It's difficult for people with BPD because they do have impaired stress tolerance. They do have problems with conflict resolution skills. However, those are learnable skills. So again, the growth mindset. People can learn how to do that. They may be challenged. It might take some time. Might take some patience. But people can learn. But a lot of people are terrified of relapse again. So a lot of people will avoid employment because they're like, we don't want to go back to that hell we were in 3 years ago. So we're not going to push it. We're just not going to go there. And then the final point that I want to make about employment is that when this comes from parents, all too often the conversation goes something like this. Honey, when are you going to get a job? Usually the response is anger, how are you, dare you talk to me, or what are you talking about, or I'm too sick, or don't you understand anything? Or later that day they'll go and cut themselves, or they'll isolate themselves in their room because they feel like you've given them the message, you're a loser, you don't have a job, what's wrong with you, why aren't you working? If you frame it in the context of, honey, we don't want you to be dependent on us anymore, they're going to hear that as, you're sick of taking care of me. You hate me. I know you're sick of me. And so this is a really tricky subject to bring up. And the way that I almost always bring it up with the patients that I work with is to talk about meaning and purpose in life. And I start with the basic question, what do you want to do with your life? Do you want your life to mean anything? If they say no, I'm going to say, that's really sad. That's really sad. I hope we can keep talking about this from time to time and figure things out because that makes me sad. If they say yes, it almost always leads to some vocational skill. Like I want to save the trees. I want to be an artist. I want to help people. Maybe I just want to be on my own. I want to be independent. I want to have a boyfriend, girlfriend. I want to just be on my own and not live in your place anymore. And then that leads to a conversation of, I want that for you too, and let's try to get you there. And then you work toward that. But you're always working toward meaning and purpose in life. You're not working toward get a job. Even if you're having the thought as a parent, get a job, it's probably better that you hold that to yourself and not share that with them. And then finally, putting it all together. So which one do I do first? A lot of people are going to ask me this. So, okay, so how do you stage this? What order do you go in? Well, psychotherapy, medication probably need to be playing a role. But again, I've heard from numerous participants of these webinars in the past, somebody won't go to therapy. They just won't participate. That doesn't mean things are hopeless for them because they can do these other things. And these other things can, in fact, help. And sometimes can help enough for that person to move on with their life. So how do you put them all together? There's no specific order. The reality is all of these things affect one another. So if somebody says, I can't sleep, but they're not exercising, you can ask them, which one would you want to do? Would you want to do one or the other? And if you can help them sleep, they'll probably have more energy to exercise. If you can help them exercise, the exercise will actually probably help their sleep. And it's the same with all of these other things. They all go together. And so I think that you leave it up to the person, and you assess which ones are relevant. But you leave it up to the person of what to work on. And I think I'm done. So I've got some time for questions.
Thank you, Dr. Palmer. We have several questions, actually, and our first one relates to something you had just mentioned about the person who refuses to get help. So someone has said, my son refuses help. How do I handle this? What can I do?
So this has been a common question, and usually when somebody's refusing help, I think if he's engaging in a relationship with you still, I would simply express concern. I would say, son, I would use his name, Jim, I'm really concerned about you. These are the things I'm concerned about. I see you laying in your bed a lot. You seem really unhappy, and that makes me sad as your mother because I love you, and I would love to help you, but I don't know how. I don't know how to help, and I wish you and you, whatever, would seek someone out who might have some answers for us, who might be able to help. And I would keep reiterating that message. And it's better if you focus on concrete behaviors or symptoms. You're laying in bed all day. You're not doing well in school, and I know you would like to do well. You seem sad to me. Those types of things.
We also have a few questions about comorbidity, which you had mentioned. Someone said, if someone suffers from an eating disorder, and this is probably applicable to other disorders as well, what's the best order to treat? Does one need to be tackled before the other? Can they both be done at the same time? And a follow-up question from someone else is, do you need to find a therapist who specializes in both?
So you need to find a therapist who's comfortable treating both. You don't need to find a therapist who specializes in both. And again, the big point I wanted to make about borderline personality disorder is you don't need a specialist. If you find a clinician, a psychiatrist, a psychologist, a social worker who is comfortable treating borderline personality disorder, is able to talk with you, says they've treated other patients and had good outcomes, that's good enough. In terms of how to stage treatment, this often comes up. So treating the disorders together is almost always better than having one clinician treat one and another treat another. So for instance, if somebody has substance abuse or an eating disorder, it's better to find one clinician who can at least try to address both disorders or all of the disorders that exist. In terms of how to stage them, it really depends on what the severity of the illness. So the couple of examples that I can think of are somebody with an eating disorder. If it's somebody with anorexia whose body weight is extraordinarily low and they are really in danger medically, that has to be addressed before any other treatment is really going to have a chance of working. If it's somebody who's an alcoholic, who's drinking, a 12-pack every night and passing out and getting, driving drunk, that has to be addressed before any other treatment can really be effective. And if one clinician can do that, that's great, but that would be prioritizing things. Just like with BPD, if somebody is actively suicidal, all the rest of the treatment kind of gets put on hold until the suicidality is under control. But in general, if you can find a treater who can do both, that's ideal. If you can't, if you need to go to different specialists to treat them, the biggest thing I want to encourage is encourage those treaters to talk to each other. Talk to those treaters and say, have you talked to Dr. So-and-so? And really make a point. Because a lot of times clinicians get busy, they don't think about it, they forget about it, and reminding them can be really helpful.
Okay, we have another question related to helping a loved one become productive with their day. And this person says, we have left it up to our daughter, but she doesn't start the process of organizing the activity. How do we get her to want to do something productive with her day?
So again, I think if the advice I'll give you is the advice I would take myself as a clinician treating her, and that would be to start with a conversation about meaning and purpose. I see you suffer. I see you having a hard time doing things. It makes me so sad. And I'm wondering, how do you feel about it? What do you want for your life? Like, what do you want, and how do you want to get there? You have to identify something that means something to the person. And if she says, I really want to be a school teacher, or I really want to find a husband, or I really want to help dogs, whatever it is, that's what you're going to latch on to and say, you know what? That would be amazing if you helped dogs. And that would be such an amazing thing. And there are so many careers that you could have that would help dogs. But how are we going to get you there? Like, you've got to get through school, you've got to get through all these other things. And in order to get through school, you're going to have to be able to get out of bed, like at 8 o'clock in the morning. And like right now, that can't happen. That's not happening. And so maybe let's work on trying to get you out of bed at 8 o'clock in the morning and come up with something for you to do so that you'll be in a position to do well in school when that day comes, so that someday you'll be able to help dogs in the way you want to. And if you identify things that are really, that somebody's really passionate about, that they actually feel strongly about, that will be used throughout the entire treatment, and that can go on for years and years. But that will be used throughout the entire treatment. So when they start having trouble in school, you're going to keep coming back to, but you want to help dogs, and I want to help you do it because I know you'll be awesome at it.
Thank you. Unfortunately, we are at time, and we unfortunately have more questions than we have time for. But I wanted to thank everybody for their participation, and thank you, Dr. Palmer, for your presentation. And we hope that everybody will consider registering for our next webinar on October 13th with Dr. Jillian Galen, who will talk about validation. And you can see the link on your screen for registration and details about that as well. So thank you and good night.
Thank you all.